Hello, I'm Edgar Lerma, a clinical nephrologist based in Chicago, Illinois. Today, I'm going to talk about team management from PCP to nephrologist and supportive education to achieve continuity of care and adherence to optimal treatment strategies in IgA nephropathy. This podcast is supported by an independent educational grant from Travere, and this podcast is a part of a video podcast series with other lectures conducted by Professor Jonathan Barrett. The other lectures are entitled IgA nephropathy, epidemiology, pathophysiology, genetics, supportive treatment, and the other lecture is dual endothelin angiotensin receptor antagonist, DIARA, blocking two different renal receptors to reduce proteinuria. What are the clinical trial data in IgAN? So as we start this, we know that mesangial proliferative glomerulonephritis, characterized by diffuse mesangial deposition of IgA, is what we see under the microscope with IgA nephropathy. We must remember that IgAN was first recognized in 1968 by Jean Berger when immunofluorescent techniques were introduced for the study of renal biopsy specimens. IgAN is unique among glomerular diseases in being defined by the presence of an immune reactant rather than by any other morphologic feature on renal biopsy, and the light microscopy changes can be variable. IgAN is the most prevalent pattern of glomerular disease seen in most Western and Asian countries where renal biopsy is widely practiced. Genome-wide association studies indicate a geographical gradient of risk. In 2021, KDIGO published its clinical practice guideline for the management of glomerular disease. Chapter 2 in that document pertained to IgA nephropathy, or what I will refer to this podcast as IgAN, which is what our topic of discussion is for today. One of the important practice points pertain to considerations for the diagnosis of IgAN. It is widely recognized that there are no validated diagnostic serum or urine biomarkers for this disease. When someone is diagnosed to have IgAN on renal biopsy, it is first and foremost important to assess all patients with IgAN for secondary causes. Secondary causes include IgA vasculitis, IgAN secondary to viruses, inflammatory bowel disease, autoimmune diseases, or even liver cirrhosis. And then there is also IgA dominant infection-related glomerulonephritis. If secondary causes have been ruled out, then the patient is diagnosed to have idiopathic IgAN. The renal pathology is then scored using the MES-C score, and this is discussed by Dr. Barrett in the other podcast lectures, which is part of the series. Once scored, the patient is then risk stratified based on clinical and histologic criteria. This is the part whereby KDIGO recommends that the patient be enrolled in a disease registry. I'm not going to go into the details of these, as these have been eloquently presented and discussed in the other program lectures. The next part of the algorithm from KDIGO pertains to the commencement of what we call optimized supportive care. Optimized supportive care entails management, in particular, use of RAS inhibition with ACE inhibitors or angiotensin receptor blockers, lifestyle modifications, and of course, addressing cardiovascular risks. One of the challenges we have had with management of IgAN for a very long time is the lack of disease-specific therapies. For many years, the cornerstone of treatment really centered on RAS inhibition, and if the patient's CKD continued to progress despite that, the next step would be the initiation of corticosteroids. However, there are several randomized controlled trials that were recently published, namely Testing, Stop IgAN, and Testing 2, whereby These studies actually highlighted that corticosteroids may actually be more harmful than beneficial on the overall scheme of treatment. There is, however, light at the end of the IgAN treatment tunnel. There has been wider understanding and recognition of the pathophysiological steps that lead to IgAN. In particular, you may have heard of the 4-hit hypothesis on the pathophysiology of IgAN. Hit 1 pertains to high blood levels of galactose-deficient IgA1. Hit 2 is the presence of autoantibodies, IgG or IgA, which are specific for the galactose-deficient IgA1. Hit number 3 is the formation of pathogenic immune complexes, which are circulating. Hit number 4 is the accumulation of immune complexes in the glomeruli, and this actually induces the renal injury. It is important to recognize that there are now promising novel therapeutic options that have arisen from better understanding of these pathophysiological steps that eventually lead to IgAN. With these novel treatments on the horizon, there has to be even better optimization and coordination between the PCPs, whom I actually consider as the first line of defense against IgAN, and nephrologists and other kidney care specialists, so that patients can receive what is appropriate and what leads to significantly improved outcomes. With IgAN being the most common primarily glomerular disease worldwide, one can extrapolate that it is indeed among the causes that can eventually lead to CKD progression. We also now recognize that dysregulated complement activation plays a role in the pathogenesis of various glomerular diseases, including IgAN. According to Dr. Anton's schoolwork, the primary care providers are the ones who are going to identify and screen patients who are at risk for CKD. And who is at risk for CKD? These are the patients with diabetes, hypertension, glomerular disease, under which IgAN falls, and polycystic kidney disease. That being said, it goes without saying that PCPs will still remain very active and provide ongoing management of these patients, and will contribute to the education that is so essential if patients are going to take charge of their disease, which is the only way this is going to be effective. So here, one recognizes the great opportunity for collaborative work between PCPs and nephrologists and their teams for betterment of the patient. According to the recently published KDIGO clinical practice guideline for the management of patients with CKD, the optimal care model involves a multidisciplinary approach to patients with CKD, and this applies to our patients with IgAN. The schematic points out the various stages of CKD, from early kidney damage, stage 1, to advanced CKD, stage 5, and points out the overlapping and cooperative roles of PCP teams and nephrology teams. Often, it's appropriate that a nephrologist see a patient much earlier, depending upon the problems. As the patients progress beyond that, nephrologists are going to be assuming an even greater role in the patient's management. The KDIGO Clinical Practice Guideline highlights the importance of clinical monitoring for the progression of CKD based upon GFR and ACR categories, and deals with the contentious issues of risk equations for predicting kidney failure risk and cardiovascular risk. This concept particularly applies to patients diagnosed with IgAN who are at high risk for progression of CKD, based particularly on the degree of proteinuria. Since PCPs see patients in the earliest stages, it is important for them to be cognizant of what to look for and what are the implications of these findings and observations. For instance, for monitoring of albuminuria, it has been demonstrated in several studies that a doubling of ACR on a subsequent test exceeds the laboratory variability and definitely warrants further evaluation. The importance of monitoring proteinuria or albuminuria is of prime importance in patients with IgAN. When one considers patients with IgAN, we need to identify who would be at risk for rapid progression of their disease. According to the KDIGO guidelines, patients with proteinuria greater than 1 gram per day are at highest risk for progression. Moreover, those who have persistent proteinuria greater than 1 gram per day, despite optimized supportive care, are the ones who are at highest risk. Remember, these are the patients who have already been receiving at least 3 months of RAS inhibition with ACE inhibitors or angiotensin receptor blockers. These are the very same patients who may be considered for enrollment in a clinical trial, which I alluded to earlier. Also, it is important to note that we have to rule out secondary causes of IgAN first, as these recommendations may not necessarily apply to these patients. Now, depending on the GFR and risk stratification, patients are then rendered various treatment options. Both PCPs and nephrologists have to be involved not only in discussing and explaining these options. It is important for both to be on the same page, as any disagreement between the providers certainly lead to increased anxiety on the part of the patient, but not only the patient, also their families, and in some instances, their caregivers. So let's go back to what I was saying earlier, that proteinuria being a marker of disease progression. As I mentioned earlier, greater than 1 gram per day in patients with IgAN, in patients who are receiving optimized treatment for at least 3 months with RAS inhibition, are considered at high risk. There was, however, a recent paper that was published called the RADAR study. This was a retrospective study looking at over 2,000 patients with biopsy-proven IgAN, adults and children who had GFRs less than 60. So you can see these patients fit the diagnostic criteria for CKD. And in this patient population, however, they have proteinuria greater than 0.5 grams per day. So I'd like to emphasize greater than 0.5 grams per day, not the greater than 1 gram per day that I mentioned earlier, that is already recognized as a risk factor and is correlating with rapid CKD progression. So in this study, with almost 6 years of median follow-up, the authors found out that even those patients who were previously considered low risk, that is having proteinuria less than 1 gram per day. In particular, this is less than 880 milligrams per day in this study. These patients actually still had high rates of kidney failure at 10 years. The authors demonstrated that at 1 ml per minute per year decline in GFR, around 40% of adult patients aged less than 50 at the time of diagnosis actually reach kidney failure within their lifetime. So think about the patients who are diagnosed when they are in their 40s, right? As PCPs, one of the questions that are front and center for patients when they are told that they have CKD due to IgAN is, what are the signs and symptoms I may experience? Or perhaps a family member might ask this. One has to recognize that a lot of symptoms of CKD related to IgAN do not manifest until late in the course of their disease. In patients with glomerular disease like IgAN, more poignant signs include hematuria, frothy urine, difficult to control hypertension, to name a few. Some of the symptoms, unfortunately, occur when there is advanced stage of CKD, when the patients are nearing requirement for dialysis or transplantation. That's why most of the symptoms of renal disease are not seen earlier. However, when they are in their advanced stages, some of the symptoms include fatigue, which is most prevalent, poor mobility, second most prevalent symptom. There's also sexual dysfunction, considered as most severe, and even poor sleep. Other symptoms, itching, shortness of breath, decreased appetite, muscle cramps, heartburn, bone pain, drowsiness, and even leg swelling. As you can see, most of these symptoms tend to be non-specific. Hence, it is difficult to pinpoint them to relate to actual disease, CKD or IgAN. PCPs should be attentive to both physical and psychological aspects when managing patients with advanced CKD, and ask patients about uremic symptoms that I mentioned at each consultation using a standardized validated uremic symptoms tool. Now, the KDIGO guidelines also emphasize a comprehensive approach and evidence-informed management strategies to support people to live well with CKD and IgAN. And the reason for this is because there really are no evidence-based options. The CKD symptom management strategies are actually shown in the KDIGO paper document. Now, let's switch gears. Let's talk a little bit about the novel therapeutic options. As I mentioned, as we understand the pathophysiology of IgAN more recently, there's now various promising novel therapeutic options. And it is important for PCPs to coordinate with nephrologists and other kidney care specialists so that the patients are given the best opportunities for optimal outcomes. For many years, we have recognized that angiotensin II plays a role in CKD risk progression from its various effects on renal vessels, glomeruli, and the tubulointerstitial compartment. And on this basis, we are well aware of the effects of ACE inhibitors and angiotensin receptor blockers, that is RAS inhibition, in retarding progression of CKD. It turns out that endothelin has similar effects as angiotensin II. In fact, endothelin 1 is a potent vasoconstrictor primarily released by the endothelium. Endothelin 1 acts via endothelin A and endothelin B receptors in antagonistic ways. ETA stimulation leads to vasoconstriction, extracellular matrix deposition, and inflammation, whereas ETB stimulation leads to vasodilatation, sodium and water excretion, anti-proliferative effects, and metabolism and depletion of ET1. So any beneficial effects of ET antagonism will be enhanced in drugs with selectivity for the endothelin A receptors. It has been shown in animal studies, disease models of glomerular disease like FSGS and IgAN, that angiotensin II and endothelin 1 individually and together have been shown to mediate glomerular injury. It has been suggested that joint therapy with RAS inhibition and endothelin system inhibitors would retard CKD progression in these diseases. Sparsentan is a dual endothelin and angiotensin receptor antagonist, abbreviated as DIARA. It is plausible that joint therapy with RAS inhibition and endothelin system inhibitors would retard CKD progression in these diseases. So now let's go to the collaboration. When should patients be actually referred to nephrologists and kidney care specialists? This is a common question that I hear when PCPs ask, when should they send patients to us? And I'd like to divide this in buckets. There are those that require further evaluation, There are those that pertain to management of complications, those that allow for planning and preparation for kidney replacement therapy, be it dialysis or transplantation, and lastly, those that require coordination for further evaluation and management. So we know that studies have shown that there are benefits and consequences of early referral versus late referral. Some of the benefits include delayed delayed um, kidney replacement therapy requirement, less need for urgent dialysis, preemptive kidney transplantation, reduce hospital stay, lower one-year mortality rate. Patients are also given the freedom of choice for which kidney replacement or therapy modality they choose. They can choose home dialysis with home hemodialysis or home peritoneal dialysis or even in-center hemodialysis. Another benefit is improved nutritional status. Another thing that's beneficial is that patients are given early access to psychosocial counseling, as we providers are able to identify psychosocial issues much earlier. On the other hand, some of the consequences of late referral include increased cardiovascular morbidity, low prevalence of permanent vascular access. So patients would end up having hemodialysis catheters placed as opposed to a fistula or a graft for dialysis. There's delayed referral for transplant, higher hospitalization rate and one-year mortality rate, and of course, worse psychosocial adjustment and in some instances, even malnutrition. So when we consider the factors that lead to late referral, we can also divide them into patient factors and healthcare system-related factors. So for patient-related factors, we're looking at the age of the patient's race, comorbid illnesses, the underlying etiology of their kidney disease, maybe non-adherence to treatment, and socioeconomic status. Healthcare system-related factors include health insurance status, the type of the referring physician and the type of referring center, also the health system and the physician rationing, and of course, distance to the dialysis center. So let us summarize what we have just discussed. The optimal care model emphasizes the additive benefits of different components in the system, policy, provider, and patient labels or patient levels in improving clinical outcomes. So key features of existing CKD care models that foster collaboration between PCPs and nephrologists or kidney care specialists include a multidisciplinary care team. This includes the nephrologist, maybe an endocrinologist, cardiologist, transplant surgeon, psychologist, nurse, social worker, pharmacist, dietitian. Interventions like blood pressure management, diabetes management, cardiovascular management, anemia management, as well as management of bone and mineral disorder. There's also issue of conservative kidney management in patients who prefer to proceed in the conservative pathway. And of course, there's outcomes, right? The outcomes that we want to achieve, we want to delay CKD progression, we want to improve blood pressure control, which translates into better cardiovascular risk. We want to improve outcomes from cardiovascular standpoint. We also want to improve the rate of optimal medications and improve patient education. So the KDIGO guidelines itemize the specific components of this model of care into education, navigation, management, and surveillance. Thank you for your attention.